Well, welcome everyone. I'm Joseph Reardon. I'm an instructor in emergency medicine at Vanderbilt University Medical Center, and having personally been involved in the placement of dozens of trauma airways, I think this is a fantastic topic for us to talk about. And so I'd like for us to all be able to get on the same page with the way that ATLS approaches the trauma airway. So we're going to start with the objectives of this session. So the objectives today are going to be, first, to recognize the signs and symptoms of airway obstruction and ventilatory compromise. Second, we're going to define what a definitive airway is for our patients. Third, we're going to describe how we establish a definitive airway. And fourth, we're going to confirm the airway's placement. So I'd like to talk about a particularly difficult case. So you're working in the trauma bay, and this patient is brought to you. This 34-year-old intoxicated motorcyclist crashed his motorcycle into a fence. He was unhelmeted, and he's rolled into your bay, and this is how he looks. You're looking at this patient, and what is your first priority when you're seeing this patient? Jason, what's your first priority when you see this patient?
Airway.
Airway, excellent. That is an excellent answer. So this patient makes us all anxious. Why does it make us anxious? Because there are so many unknown fields in establishing this patient's airway. We don't know what we're going to be getting into next, but an organized approach is going to help us out. So this patient, he smells of alcohol, he's belligerent, he's slowly desaturating, we're at 85%. We're going to talk next about how we're going to assess this patient systematically. So we're going to talk about recognizing the symptoms and signs of airway obstruction and compromise. So when you're assessing a patient, what are some signs and symptoms that tell you that the patient is having a need for an advanced airway? Nicole, could you give me some examples? Exactly.
They can't talk or phonate?
Exactly.
Hypoxic, vital signs will show signs of respiratory distress, perhaps low O2 levels, might be breathing very fast, trying to make up for that.
Great. So you've all gone onto important points. So these are all affecting different aspects of the ability to appropriately oxygenate. So if somebody can't phonate, perhaps they're having a physical obstruction to their airway. Perhaps they're having some difficulty actually controlling their airway from a neurologic perspective, and perhaps they're just not oxygenating because of a lung problem. So when we're assessing the patient according to the ATLS guidelines, an adequate airway is going to be a patient who's alert and oriented, he's talking normally, has no injury. When we're assessing somebody who needs an airway, they either have an airway problem, they have a breathing problem, or they have a disability problem. The airway problem is going to be quite easy. As you said, they have a change in voice. Breathing problems are going to be things that you can see by your physical exam. They have tachypnea, they have dyspnea, you see a low pulse oximeter. A disability problem is also going to be easily found on your initial physical exam. They're going to be agitated, they may have an abnormal breathing pattern. So we've established this patient needs an airway. Now we need to define what a definitive airway is. I was always taught a definitive airway is plastic between the cords. Now ATLS is a little bit more diplomatic in the way they say this. A definitive airway is a secured tube in the trachea with a cuff below the vocal cords and an enriched oxygen ventilation source. So this includes things like an advanced surgical airway. So when we're thinking about how we're going to establish, and maintain a patent airway, there are the easy airways and the difficult airways. Let's start with the easy airways. So we want to start with supporting the airway as best we can with airway support techniques. We want enriched oxygen. We want the head tilt chin lift. We want the jaw thrust maneuver when possible. Then we want to go ahead and proceed with our adjuncts to assist our airway, our nasopharyngeal airway, our oropharyngeal airway. And then finally, we're going to prepare and perform our endotracheal intubation. Now what happens if our intubation is running into trouble? This is going to be our difficult airway. So we want to be prepared for the difficult airway. We're going to start by preparing by identifying the difficult airway. We're going to start with identifying the predictors of a difficult airway, assessing how we're going to find a difficult airway using the Lemon mnemonic, looking at the airway, evaluating the airway, assessing the Mallampati score, looking for an obstruction and assessing neck mobility. So we're finally going to confirm our airway placement by making sure that we've got end-tidal CO2, we're watching the chest, we're auscultating, and finally making sure we have an adequate pulse ox and chest x-ray. What questions do you all have? Are you ready for your anesthesia boards?
That's it?
That's it.
Okay.